Hello, everyone. I'm Divya, your host for the session today on behalf of Building Accessible, Safe, Inclusive Indian Cities program at NIUA. And I welcome all of you to the lecture series Think Urban, Think Inclusive. This is an 8-part lecture series themed Think Urban, Think Inclusive, which focuses on discussing approaches for making Indian cities more accessible, safe, and inclusive for all. The series is designed as a discussion with key sector experts and change makers to focus and collectively think and discuss ways to improve lives and empower persons with disabilities, elderly, young children, and their caregivers. Couple of housekeeping points. This is a pre-recorded event. The platform has a delay sometimes of around 10 seconds. So while recording, depending on the internet connection, you may experience some latency in audio and video. The entire lecture will have closed captioning, including at the bottom of this recording. The session is designed in a concise format with a short introduction, setting up of the context, 15 to 18 minutes presentation by the presenter, and a round of Q&A. If you're watching this on YouTube, we encourage you to use the comment section to leave your feedback, post questions. Audience, let me take a minute here to introduce our South Wing of PHFI and Director of Health, Eye Care and Disability at the London School of First Department of Community Ophthalmology Asia Center for Disability Inclusive Development at Hyderabad, which is also a center for public health and disability. Dr. GVS Murthy completed his MBBS from Guntur Medical College in 1979. He's an MD in community medicine from AIIMS, New Delhi from 85, and MSc in community eye health from the Institute of Ophthalmology, University College of London, UK. He has been ranked among the top 2 research scientists of the world by a study conducted by Stanford University in 2020. He's worked as a faculty at AIIMS and MGIMS Sevagram and as a medical officer WHO Geneva, an M&E consultant with UNAIDS South Asia earlier. He has published more than 350 papers, including 275 of which are peer-reviewed by renowned international journals, and contributed 15 chapters, multiple chapters to 15 books. He has supervised many PhD, MD, MSc students till date. With this very, very impressive portfolio, we welcome Dr. Murthy to our session here. I will briefly introduce the subject that we're going to be talking to him about today, which is on inclusive public health measures and its long-term benefits for all. We do understand that COVID-19 has impacted all of us. However, the severity of its impact has been much larger on persons with disability and elderly, primarily because of them being under a high-risk category and also reduced access to basic facilities. Also, with the COVID-19 shifting the focus of healthcare facilities to positive patients and curbing the virus spread, the inaccessibility to health services and medical facilities, particularly for this vulnerable group, has increased. Other main challenges include hand washing, sanitization, accessibility to caregivers, and inaccessibility to PHCs and other specialized medical support. Although there has been many efforts that our government and organizations across India have been taking forth to ensure we can curb COVID-19 spread and also take care of persons with disabilities and elderly during this time, there is a lack of research in this domain, and efforts remain unsuccessful to a large extent. So the intent today through our discussion here would be, as India is slowly moving towards a rebuilding better phase post the pandemic, how do we create a disability conscious ecosystem and ensure that the persons with disabilities and elderly are taken into consideration and their needs and their requirements are considered and addressed in a more stronger and more comprehensive manner. So in order to build stronger safety nets within our society for all of them. On that note, I would like to invite Dr. Murthy to share his insights and presentation on the subject. Welcome, Dr. Murthy.
Thank you, Divya, for that brief about what I'm going to speak about today, in addition to the introduction. It's a pleasure to be with all of you. Namaskar to those who are listening in to this pre-recorded lecture and the Q&A session that follows after that. So I'm now going to share my screen and let you know about what this issue about when we're looking at people with disabilities and why we need to look at the inclusivity, which is so critical when we're looking at people with disability. So if you look at people with disabilities, and this includes all disabilities, whether it is hearing, whether it is physical, whether it is vision, intellectual, so all these are different types of disabilities, and the Disability Act that we have in India now includes 21 conditions which would be classified as a disability. So when you look at people with disabilities, one thing that stands out is their health needs are much higher compared to the health needs of the others in the community. But at the same time, you find that there is a 2 times higher likelihood of people with disabilities finding that the skills and the facilities that are provided for healthcare are inadequate compared to what other people would mention. They also perceive that they are 3 times more likely to be denied healthcare. And this is because of the stigma and the sort of insensitivity that exists when we come to people with disabilities, and 4 times more likely to be treated badly by the health system. And treating badly by the health system does not mean that they are not given the medication, but the way they are giving the medication, the way they are consulted, the way they are interacted with when they visit hospitals. So all these are important things, despite the fact that people with disabilities have twice the need for healthcare compared with the others. These situations are related directly to accessibility. And there are barriers in 2 different domains when we are looking at how people with disabilities are able to access health services. One domain deals with the physical environment, and that is the inaccessible buildings. You all must have seen that if somebody wants to enter a government building or a private office, they would find it very difficult to go in, let alone getting their issues sorted out. There is hardly any signage which tells people with disabilities. The hearing impaired can see a sign, but you don't have these signs anywhere. A physically challenged person can also see signs, but there is hardly any signage. And then we look at these supportive mechanisms in the physical environment. And a lot of people have to travel to a health facility, which may be quite far in some cases, because you need to, let's say if you're living at the fringes of a city, then it could be, some place like Delhi, if you're staying outside Badarpur, and if you have to reach the All India Institute of Medical Sciences, a distance of about 25 kilometers, and not made easy because of our unfriendly transport systems. On the other hand, the other domain which impacts on the access of people with disability to health services is a social cultural context. There is stigma regarding people with disabilities. They feel that they would not be treated in the same manner as others in the society would. And then when it comes to the health staff, you find that a lot of insensitivity exists amongst the health staff. They don't know how to interact with a person with disability and use terms which can actually turn off a person with disability. So things like andha hai, kana hai, these are terms which are derogatory and also reduce the self-esteem or self-worth of people with disability. And therefore, they feel that they have no place in society. There is also an overriding feeling amongst many health providers that people with disability are anyhow worthless. They can't contribute to society. And so whatever we do is more like charity, and they have no rights that they can demand, which is unfortunately not true, but is the way things are. So both these barriers, the big baskets of barriers, whether it is physical or social cultural, both need to be targeted if we need to look at an inclusive society and an inclusive health paradigm. I will look at some of the evidence that we have generated over the last 10 years from some of the studies that we've done in the southern part of India. I'm based at Hyderabad, and therefore a lot of the work that I would refer to is in the Telangana region and the bordering districts of Karnataka and Andhra Pradesh. So we did this Telangana disability study in the Mehboob district, which is adjoining Hyderabad. And we looked at both children as well as productive age group adults. When you look at children, there are 11 times less likely to be out of 11 times more likely to be out of school compared to other students of a similar age cohort. Similarly, they are likely to be 6 times more likely to be in a lower grade in the class compared to others of the same age cohort. And in terms of their health problems, if you look at children, they were 4 times more likely to have reported a serious health problem within the past 12 months. And we define a serious health problem as one which requires admission to a hospital. When you look at productive age group adults with disability, they were 3 times more likely to be the poorest quartile. That means they were the poorest group amongst the general population compared to the rest of the population who were not disabled. 5 times more likely not to have been working in the past 1 week. And we looked at a week's period of recall because much of the employment is not continuous, it is seasonal, and therefore looking at the past week made sense. Again, amongst the adults also, we find that they were 4 times more likely to require hospitalization within a 1-year recall period. So both for the children as well as for the adults, health is a major concern, and therefore trying to make services accessible is very critical. Another series of studies that we did in Telangana and the Karnataka districts was what we call as a South India disability study. And here we looked at comparing certain parameters between people with disability and those without a disability. Look at employment status, 43% and above amongst people with disability compared to about 17% amongst those without a disability who are currently unemployed. Ever hospitalized, again, a very different situation when it comes to people with disability compared to people without a disability. Current medication, 9% amongst people with disability compared to 5% amongst those without a disability. A non-communicable disease, diabetes, was very, very significant in terms of its prevalence amongst people with disabilities, 12.5% compared to less than 1% amongst people without a disability. Feeling low constantly, which is a proxy measure for depression, again was significantly higher, 10 times higher amongst people with disability compared to people with no disability. So we find that the health needs of people with disability are far higher than the others in the community. Let's look at the healthcare access, because we know that they have more health problems. Do they therefore get more in terms of health access or healthcare? The difficulty in reaching clinics, which is the transportation perspective, significantly more of a problem for people with disability compared to those without a disability. Once they reach the facility, then they are confronted with staff who behave in a condescending manner, because they feel that people with disabilities are absolutely of no use to society compared to people without a disability. We hear of complaints even amongst people without disabilities, but it is much lower. The access in terms of the spaces within the health facilities, in terms of ramps, in terms of handrails, in terms of navigating themselves within the hospital campus, that again was not very friendly. And the cost for transportation, because the way our public transport is, a person who's on a wheelchair would find it frighteningly difficult to get onto a bus. And if they have to use something like a private taxi, then the costs of transportation increase dramatically. Other features that we found from the study in the two states of Telangana and Karnataka was that disabled people visited hospital 2.5 times more compared to people without a disability. I've already mentioned about diabetes, but converting that into the higher risk, a 19 times higher risk for people with disabilities compared to the others. And this is because they lead a very sedentary lifestyle. They have very high levels of stress. And because they are wheelchair bound or homebound, there are no exercises that they are helped with. And therefore, the risk of diabetes and hypertension increases exponentially amongst people with disabilities. Not getting the health services when they needed it. So if they had an emergency, getting transport to reach the hospital was a problem, and therefore they were not able to receive services in time when they required it. Let's look at a subcategory of people with disability, and let's look at women. And women with disability reported significantly lower antenatal care. The birth of a child is perhaps even more precious for a woman with disability, but then they receive less antenatal care compared to the others in the community. And when they did get care, you find that they had double the complications reported during pregnancy compared to women without a disability. So it comes out very clearly that people with disabilities and subsects like women and children with disabilities have far greater health needs. And unfortunately, these health needs are not being adequately met. So in terms of looking at what could be the causes of reducing this access, we also undertook accessibility audits in the state of Telangana, specifically in the city of Hyderabad. And why this is important is because without access to facilities and services, people with disabilities will never be included. And that is something which we have to guard against, because we have now embarked on the Accessible India campaign. And if that be the situation, then we need to look at how our facilities can become more accessible. Also to remember that India is a signatory to the UN Convention on Rights for People with Disabilities. And at this convention declaration, India also signed the declaration, and Article 9 of this declaration obligates all the governments to ensure access to people with disabilities on an equal basis compared to the others. And when we say ensure access to people with disabilities on an equal basis, it doesn't mean that you say that, okay, my hospital is open to everybody. What it means is, what extra are you doing to get the people with disability into your hospitals so that they can access the care? And this applies not just to the physical environment, the two broad domains that I talked about, physical and socio-cultural. This applies to all those aspects: the physical environment, transportation facilities, information on, say, COVID appropriate behavior, communication of where services are available, packaging material in an accessible format, and all the systems which are important for social development, including the health system. All of it is covered under the Accessible India campaign. And therefore, it is our duty to try and make a difference. So we did this accessibility audit, like I mentioned, in Hyderabad, and we looked at the Greater Hyderabad Municipal Corporation building. And on the other side, we looked at health facilities like the Osmania General Hospital, which is one of the biggest hospitals in the southern part of India. If you look at the corporation offices, the main entrance, not accessible. The handles to hold on were very high, no automatic doors, no ramp, no handrails which people can hold and get up the stairs if there was no ramp. The reception area where you would want to find out about your problems, the counters were situated very high and were not accessible to a range of people with different impairments like hearing, physical, or vision. There were obstacles in the corridors, shelves lying out in the corridors, and we've seen these buildings. Many of us know what I'm talking about, where all the wardrobes or the storage racks are in the corridors. Toilets not accessible, and if you want to spend some time in the corporation office, which generally we find takes a lot of time to get your work done, and if there are no accessible toilets, that is an issue. No signage, and to help drop off people with disabilities or help their escorts or attendants to park, there were no designated areas and the parking lot was very far, so that for a person with disability to come to the building itself would be a nightmare. Let's look at the Osmania General Hospital. There is a ramp, but the ramp is placed at one end. It is inconvenient and not easily visible to people who come to the hospital. There is no continuous handrail. There are handrails intermittently, but that doesn't help a person with disability to actually come up. There were no designated spaces inside the hospital for them to sit, wait for their consultation, or for meeting up for their lab results or getting their lab tests done, etc. All the counters were very high and they were inaccessible to somebody in a wheelchair who would like to come to the hospital. There were no automatic or revolving doors, so that people would have to depend upon somebody else to open the door. Once again, obstacles in the corridors, a lot of material lying in the corridors. Elevators were present in the general hospital, but they were inaccessible. The control panel on the elevator was very high. There were no facilities for tactile navigation, which is important for visually impaired, or no signage for the hearing impaired. Toilets were inaccessible, just like in the municipal corporation office, and the water taps were again not accessible. Just to give you a brief idea of what I'm talking about, here were some of those images. So you can see that there is no handrail and it's a steep staircase. And if people with physical disability have to climb up these stairs, it is a nightmare. Even the somebody who is visually impaired, who needs to hold on to something to climb up, even for them, it's a problem. These sort of Indian toilets are not suited for people with disability, and therefore there is no access to toilets. Look at this particular staircase, which is at the Osmania General Hospital. Too many curves, and it makes it very difficult for somebody to navigate themselves. Here, you find there is a handrail, but it is not continuous. Suddenly, here there is a very difficult situation for somebody who needs to hold on to that to actually access the building. This is the main entrance to the Greater Hyderabad Municipal Corporation office. No ramp, steep steps. And this is something which many of you would have seen. And we need to make a difference in these sort of, at least the physical environment to start off with, to make a difference. Very recently in 2020, we looked at the impact of COVID-19 on people with disability. And this was a mixed method study, which means it had a quantitative element as well as a qualitative element. And this was conducted across 14 states in India and covered more than 400, that is 403 people with disabilities. And the main objective was to look at what was the level of disruption to their activities during COVID. We had a good representation of different disabilities, 51% physical, because that is the commonest. 16% were people who were blind or were visually impaired. 11% had intellectual impairments. 9% had speech and hearing amongst the people with disabilities who were contacted. 42%, that is out of every 5 people, 2 people and more stated that lockdown had disrupted access to their routine medical care. For their examinations, they could not go out. And you find that those people with disability who had another health problem, like say diabetes or hypertension, they found it even more difficult. So they had significantly worse off situation in terms of medical care. More than half the people who were interviewed, half the people with disability, their single-minded thought was that if the lockdowns had continued longer, then they would have found it very difficult to manage their day-to-day living. So there would have been a deleterious effect on their own health. You look at, again, service aspects of the COVID pandemic. So nearly 60% of those who need rehabilitation services, and remember, a lot of the physically impaired people with disabilities, they need physiotherapy. Children who have cerebral palsy, they need regular physiotherapy. Without that, they can't even feed themselves or sit stable in a chair. So they need rehabilitation services continuously. 82% reported moderate to severe stress levels. And we know that COVID has had an impact on the mental health status of everybody, but it has singularly affected people with disability far more than people without a disability. Livelihoods were impacted almost universally. 84% stated that their livelihoods were impacted, and a third found it difficult to get their pensions. So in many states, pensions were not released in time because of COVID, and there was no priority for people with disability. Because of those situations, they had to borrow money. Nearly half, 46%, had to borrow money, and a proportion of them at very high interest rates. 54% stated that their social participation was affected. And this understandably is so, because they could not move out of the house. They could not meet up with their peers who were disabled, or their health personnel who could, or their counselors. Of course, marriages and all did not take place at that time, but even other social activities were impacted upon. Special assistance, if you're looking at how we can address that situation, we need to look at special assistance and disabled-friendly COVID protocols, which must be available and accessible to disabled. So this includes even, your sanitizer. A routine bottle of sanitizer placed at a height is not possible to be used by a person with disability unless you have visual, that is tactile and visual signages. It will not be possible for them to look at following any protocols. So you need to look at people with disability with a different lens and try to make the world more comfortable for them in a situation like a pandemic. We also need to look at some of the things which worked well. So we know that in terms of medical care, teleconsultations work very well. So looking at tele-rehabilitation, so at, you could use the UGC network, or, you have the Doordarshan network, where you could have regular rehabilitation sessions so that mothers of children with disabilities can support them, and adults who require some sort of therapy could be helped by attendants at home, their caregivers at home, to do exercises if they cannot come to a hospital location. As we found that stress and anxiety is high, and therefore online counseling to reduce these stress levels is again very critical. But there is an onus on our respective governments, the state governments as well as the national government. And this looks at how do we ensure relief measures, maybe special financial packages, subsidies, furlough schemes, interest-free loans, so that their current livelihoods and an assurance of their pensions, so that they do not end up in a catastrophic situation where they cannot spend for their health needs. So these are certain things which we found from the study that people with disabilities felt that they could benefit from. And therefore, we need to look at how do we systematize these things and make a difference. And this is important. The way forward is only inclusive health. India is a signatory to the Sustainable Development Goals, and by 2030, we are looking at attaining a significant proportion of Sustainable Development Goals. The states are, in a way, assessed in terms of where they have reached with specific Sustainable Development Goals, and countries are also reviewed according to that. So I will just look at, SDG 3, which is looking at health specifically. And all the evidence that I just shared shows that people with disabilities have significant health needs, but action to improve access is yet inadequate. Sustainable development goals, whether it is goal 3 or goal 8 or goal 10 or any of the other goals, they cannot be achieved without meeting the needs of people with disabilities. And therefore, there needs to be an emphasis on affirmative action, doing more than what you do for the general population to ensure inclusive health so that nobody is left behind. And all people, including people with disability, must be able to be provided and access health services. And that is how we can make a beginning for inclusive health, and over the next 9 years to achieve the Sustainable Development Goals. Like people with disabilities say, mind the gap. Our health is everybody's concern. It is not just the concern of people with disability to take care of their own health. All of us in a one society approach, in an inclusive approach, need to look at doing that bit more, bringing in affirmative action to make a difference to the lives of people with disabilities. Thank you for your attention.
So on that note, thank you for your detailed presentation on this subject, and also bringing out a lot of knowledge from the ground, which is very important and very relevant for all of us here. Also, although you've managed to skillfully address various aspects through your presentation, I would still like to take this opportunity to probe you with couple of questions and better understand and discuss some of these aspects. So I would want to start off with this question that, WHO study suggests that affordability of health services and transportation are two of the main reasons why persons with disabilities do not receive the much needed healthcare, in low income countries particularly. How do you think cities and city level decision makers can respond to this aspect, and what innovative and action oriented methods can they utilize to mobilize some of these changes?
Yeah, I think that's very important, even from a national perspective. Like I just mentioned, India has signed up to the UNCRPD declaration, and then we have our own Accessible India campaign. And therefore, it is very, very critical that we make a difference to the way healthcare or any of the developmental agenda is delivered. And it is imperative that this is the time that we start initiating measures to make a difference over the next perhaps 5 years or so. And I think starting off with the cities is again very important. When I say cities, I'm looking at all urban areas, because at least one dimension, that is distance, is taken care of. You are within a confined space. So this becomes sort of an experiment or an experimental lab where you could try out things which work out and then try and replicate some of those for the other parts of the country. And we also know that at the moment in many states, urbanization has increased dramatically, and especially the southern part of India and the western part of India, between 40 to 50% in some states is already urbanized. And therefore, we could perhaps start looking at that. And there are some things which could be done immediately. Example, like I mentioned about the accessibility audit. So I think it is very critical that we start looking at an accessibility audit of all the hospitals and the health centers within the urban areas, and try and look at where we can improve things to improve access. So the physical environment aspect, I think, can be immediately done with. So whether it is constructing ramps or setting up dedicated information centers, a more receptive reception area, providing wide lifts, automatic doors. Now, these are all doable with a very small cost. This is not something which is going to cost the moon. And therefore, I think what is required is the will to do this. There is a policy now with the government stating its intent and with the Accessible India mission. And therefore, what we need to do is bring in that bit extra to actually make our hospitals more friendly to the people with disabilities. When it look at the other aspect you mentioned about transportation and travel around, when I'm in the UK or I'm in Germany, when I'm in the US, what strikes me is that a person in a wheelchair or with a white cane standing at a bus stop, the bus stops there and the driver immediately lowers the entrance. So there are ramps. It comes out like a sliding ramp onto the road on which wheelchair can be pushed into the bus. Now, we've already got new era buses in most of our cities under the urban renewal mission, and just adding a bit of a hydraulic system to actually lower the steps and build and put a ramp on top of it like is done in the other countries is not difficult. It may increase the cost by about 20,000 for each bus, but 20,000 for a bus which costs 10 lakhs to 15 lakhs is a small amount of money when it makes a difference.
Yeah.
I think it is more in the mind that we miss these things. I'm sure if you bring it to the attention of policymakers, they would be able to do that immediately.
Yeah.
I
It's very
think that could,
interesting. Yeah. I think
and
what,
this is seen all over the world. So
yeah.
not something which is unique, and an emerging powerhouse like India. When we call ourselves an emerging economy, we should also invest in these steps.
Yeah.
Public, for people with disability, and one or two attendants should be made free. They should not be made to pay. In a city like Delhi, if women are allowed to travel free on buses, I think all the cities in India, all the urban areas should provide free transportation. In addition to that, I think for the private sector, some sort of an incentivization so that they make their premises more accessible. So if you say, okay, there would be a recognition of your efforts, then maybe a lot of the private sector would also take care of, making that part of their agenda. And I think to make these things work, another aspect that we need to look at is, if you look at a scheme like the Ayushman Bharat scheme, now Ayushman Bharat covers people below the poverty line and it doesn't cover the entire population. So people with disabilities, if they are considered as part of the vulnerable population along with below the poverty line, and their services are covered, I think it makes a big difference.
Yeah.
If you have to pay for insurance, then having a separate subsidized or lowered premium for people with disability would actually make them go in for insurance schemes. So both at the Ayushman Bharat level, where people with disability should be included, as well as in private insurance, medical insurance, I think having a different premium calendar for people with disabilities would go a long way. On top of it, the most important domain is the socio-cultural mindset. How do we make a change to the attitude of people? And I think there's an urgent need to sensitize all the personnel in the development sector, specifically in the healthcare sector, so that they start understanding the lives of people with disabilities and make a difference. So these could be some things which can be done without too much of a cost to it, but can make a tangible difference, Divya.
You've answered two of our questions, follow-up questions to already, because we wanted to talk about this whole idea of public-private partnerships, particularly within the medical health uh, ecosystem. How that can become a game changer for the government as well, because then the pressure on the government is also not as much on providing for the facilities, and also there's some amount of support and collaboration in that sense. And you already highlighted the need for training and capacity building of medical healthcare service providers and staff, and to become more sensitive, to become more cognizant of needs of persons with various disabilities, and sort of work better given the environment and given their needs and their uh, understanding their requirements better and address that. I also wanted
Yeah, so
to.
on that, Divya, when you talk about um, the involvement of the private sector, I was talking earlier about the buildings being more accessible. But there's an urgent need for public-private partnership because they optimize resources.
Yeah.
One sector like the government has the physical spaces, the buildings, etc., are there, but they lack the dedicated human resources. A lot of the government sector, there's a shortage of human resources. So in a public-private partnership, when people come together, the buildings of the government can be used by personnel from the private sector to provide services. And we've seen a lot of good examples like this.
Mm.
One of the important endeavors has been, the MOUs which were signed by many state governments. If I remember at last count, there were about 11 state governments which had signed an MOU with the Karuna Trust, which is an NGO based out of Beluru. And all the physical buildings and human resources within the government setup are placed at the disposal of the Karuna Trust to manage the primary health centers and the secondary level facilities. And this has worked wonderfully well, to the extent that when Karuna Trust wanted to withdraw, the governments refused, say, no, 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 please continue, because they find that there is a value in that. So that is an example which has worked. Similarly, if you look at the All India Institute of Medical Sciences at Delhi, AIIMS, they partnered with HelpAge India to improve geriatric care services, and that has been running for more than 12 years now, very effectively. Then state governments have actually signed up MOUs. I can recall one example of the state of Andhra Pradesh signing an MOU with a cardiac team in Hyderabad to use the facilities of the Government Medical College of Guntur and operate there, bring in their expertise. And this has been working for 6 years. And a lot of people have been able to get cardiac services of the top quality at a government facility, facilitated through an MOU and a private player coming and operating there. In addition, I have worked for a long time in the eye care sector, and the National Program for Control of Blindness and Visual Impairment had a very unique scheme in the 1990s and up to 2005, where they were giving, special grants to eye hospitals to set up facilities in the smaller urban areas, and the repayment to the government would be in terms of number of free cataract surgeries or subsidized cataract surgeries they would do, instead of giving the capital amount back to the government.
Yeah.
In addition, a grant in aid was provided and is still being provided for every cataract surgery or a laser surgery for diabetic retinopathy by the national program to the not-for-profit sector, who's willing to set up facilities and manage these services. So there are these excellent examples, both for the elderly, and when I'm talking about blindness, that is one group of people with disabilities. There are these services, and these have worked tremendously well. They can be scaled up, but we need the intent to do that in terms of building more public-private partnerships there.
Yeah, very, very interesting. And I think your examples are very helpful and very resourceful as well, because even to us and to our audience, it opens a lot of new ways to look at certain aspects and find better, mechanisms and solutions to start discussing with cities and with decision makers as well. I think one last question that I want to put across is that your vast experience in the southern states and working with so many cities across India as well. What do you think role of technology, how that can play an important pertinent role towards empowering both decision makers at the city level and also vulnerable populations, such as persons with disability and elderly and children to some extent, in ensuring their everyday freedoms in urban areas?
Yeah, I think that's again a very important dimension that we need to look at. And in a digital age, if we do not use or harness the power of technology, then we are falling behind by 20 years. One good thing that COVID did, what it actually did was disastrous and catastrophic. But one good thing that it did was the realization that technology can play a very important role in healthcare.
Yeah.
And find that all the hospitals moved on into a teleconsultation mode for reaching out to people with general population, including people with disabilities, of how they can actually consult if they have a problem. Even here in the UK, where I'm today, when I'm speaking to you, um, the entire national health scheme of the UK government allows teleconsultation. And if you have any symptom of COVID or you suspect to have COVID, you don't go into a hospital. You should directly do a teleconsult. And I
Yeah.
think the potential of technology has been embedded in teleconsultation very clearly. If
Mm.
you were to look at people with disabilities, like I mentioned earlier, telerehabilitation is also something, in addition to a consultation process, which can actually make a big difference to lives of people with disabilities. You can do your exercises online. You see all these yoga sessions on
Yeah.
television, whether it is Ms. Shilpa Shetty, or earlier during my younger days, Mr. Dhirendra Brahmachari, or Baba Ramdev now. So all of them are doing exercise on a television screen and a lot of people are following them. Why
Yeah.
can't we look at that digital technology being used to make a difference to the lives of people with disability by having tele rehab services? The third thing where technology helps is the need for electronic medical records. You know,
Mm.
most of the records in most of our hospitals today are in paper format. And COVID has taught us that your paper format may be in the office and you're stuck up at home and you have no access to your records.
Mm.
You have a digital health mission now, which the government has embarked on. And I think EMRs, or electronic medical records, should be a priority. It helps in carrying a record, the portability of records. So you
Yeah.
may be in Delhi, but you're traveling to, let's say, Mumbai to meet your parents, and your records are coming with you because they're in electronic format. And if you, by any unfortunate circumstances, need to consult a doctor in Mumbai, the records are there because you don't have to carry your physical records. It makes life easier for the providers also,
Yeah.
because they know all the investigations which have happened earlier. And
Yeah.
at once, they can make a better diagnosis and a better clinical judgment. So that is another area where technology plays an important role. Medicine prescription. You know, you don't need every person to walk into a hospital just for a repeat prescription. You know, most of our hospitals in the government sector in India, you are given a maximum of 1 month's prescription. So you
Mm.
have to go. Why do you need to just getting a prescription? Why do you need to go to the hospital? You're a person with disability, finding the transportation, finding an accessible hospital for you to attend, it is going to be a major problem. Why not have electronic prescriptions without people having to come into the hospital? And if the government of Delhi and some other state governments can deliver alcohol at home, I don't see any reason why we cannot deliver medicines
Mm.
at home, which are more life-saving rather than life-destructing like alcohol. So when those opportunities exist, why don't we use it for a better way of reaching to people with disability? It also helps improve your communication and information. If I
Mm.
have an accessible advertising clip on how to use a hand sanitizer, it is very easy if I can animate that for a person who is hearing impaired but can see the animations and then use that. Or I'm giving a very good description for a person who is blind but who can hear it and therefore can act upon it. So technology definitely helps over there. Your communication material improves dramatically using technology. And if you're looking at one step forward, we talked about sensitizing a large army of health providers and development workers in India. How do you do that very rapidly? By using digital technology. You have all these massive online programs which are now available, which are absolutely free. And the government setting up a center which is supported to develop the material and then deliver it using a MOOCs platform, so that you reach a much larger number of people within a very short time, I think is again a big gain that technology plays. We looked at accessibility. So monitoring the progress of accessible buildings or accessible hospitals and trying to pinpoint using your GPS coordinates in a digital format with the pictures of that area, I think to go to the policy makers and say, look, this is a situation yesterday, not 20 years back, but yesterday. So you need to do something about this. So technology has a multifaceted role: delivery of services, information sharing, auditing, monitoring, as well as reducing the overcrowding in hospitals, so doctors can spend more time with patients who require their time for consultation compared to people coming for repeat prescriptions. So yes, this is the digital age, and we must harness technology to its fullest.
Thank you, Dr. Murthy. Your presentation and the discussion has been really insightful, and also it kind of resonates not only with our program but also your commitment towards building better and making a more accessible urban ecosystem is kind of very visible and very much there with us, like through your conversation and through your presentation. And we are very happy and very glad that you took our time and and enthusiastically put this together for all of us. And on behalf of our basic program and NIUA, I would like to thank you for taking out time and sharing your thoughts through this session. And it has been really wonderful from to hear from you and realize the need to find innovative ways for better public health measures and building better safety nets for everyone. And before we close this session, I would just like to remind our audience that the lecture is part of an 8-part lecture series and can be easily accessed on the National Urban Learning Platform and also on NIUA's YouTube page. And the link for both will be there in the description box below. And thank you, Dr. Murthy, and thank you to all of us.
My pleasure, Divya. Thank you very much. And hope technology plays an important role in the future.
Yeah, it is playing a very important role through our lecture series already. We can reach out to so many more people through this.
Absolutely. Thank you and have a great day ahead.